Hello, everyone. I'm Dr. Muriel Gillick. I'm a professor at Harvard Medical School and a geriatrician and palliative care physician. And I want to talk to you today about managing your frail elderly patients. What I'm going to argue is that caregivers are the key. If you think about why managing frail elders is so draining, you're immediately going to think about how it's very time-consuming. Those patients just don't seem to get better. Maybe you don't know that much about geriatric syndromes, falls, incontinence, dementia. And then your patients keep ending up in the hospital. So what can you do? To save time, you may want to use an interdisciplinary team, and I'm going to suggest partner with the caregiver to avoid what I call the no cure trap, this frustration that people don't get better. You'll want to engage in advanced care planning with the patient and ideally the caregiver. To compensate for your lack of knowledge, you may want to refer for geriatric consultation, do typical things like taking continuing education courses. And to prevent hospitalization, once again, the key, I'm going to argue, is partnering with the caregiver. So what I want to focus on today is how to partner with caregivers. And in order to do this, you'll realize that caregivers need to be educated as well as you. And that's why I've written the book, Caregivers Encyclopedia, which I hope will help your patients and their families. So step one for you is to identify a family caregiver. You need to just ask the patient to say who the person is in their family who helps them out. You're going to need to document the name and contact information of the caregiver in the record, and then meet with both of them. I do want to remind you that the CARE Act is the law in 38 states. It stands for Caregiver Advise, Record, and Enable, and it basically just demands that you do exactly these things. Step two is to review the underlying health status with the patient and the caregiver. That means reviewing medical problems, but in addition, functional status, cognition, and emotional well-being. It involves then discussing the individual medical problems and their likely trajectory, not just life expectancy, but what the person can anticipate in the coming months or years, in a broad way of speaking. And then put it all together. Clarify if the patient is robust, physically frail, has dementia, or is near the end of life. And I like to use this little schemata showing robust patients at one end. That's not what we're talking about here today. They usually don't need family caregivers, and people dying near the end of life at the other end. And then the majority of the patients we're going to be discussing today that are the real challenge for you in management, those who have physical frailty, cognitive frailty or dementia, and the combination of both frailty and dementia. The next step is to determine the goals of care. That is, given the patient's values and preferences, and also given the underlying health status, it becomes important to discuss goals with the patient and the caregiver. Is the goal to live as long as possible? Is the primary goal to remain comfortable? Is it to maximize daily functioning, seeing and walking and hearing and reading and thinking? And then how does the patient prioritize those goals of care? Again, this is my simple schemata where there are three principal medically important goals of care. And of course, most people want all of them, but we all know you have to make trade-offs in life. And the question is, which is most important to this patient in front of you? And does the caregiver know what is most important? The next step is to develop algorithms for managing chronic problems. You'll want to enumerate the chronic medical conditions, and for each problem, review the medications, delineate management strategies, discuss the likely trajectory and complications. This is just a slide to remind you that chronic conditions are extremely common in older adults, with 80% having at least one chronic condition and 68% having two or more. High blood pressure, high cholesterol, and arthritis are the top three, with ischemic heart disease and diabetes in close pursuit. So let me give you an example of what I mean by devising a chronic disease management strategy for the caregiver. For congestive heart failure, one of the things you're going to want them to do is to weigh the patient, probably daily. For high blood pressure, you're going to want periodic blood pressure checks, which means that the family caregiver needs to have a scale for the first one and a blood pressure cuff for the second one at home. For diabetes, you're going to want glucose monitoring. And while the patient may be able to do that himself or herself, for many people, it's going to require a caregiver. And then for all conditions, a crucial part of the caregiver's role is medication administration and management. Step 6 is to develop algorithms for responding to acute problems. Here you're going to need to use a symptom approach. Patients are not going to say, I'm having an exacerbation of my congestive heart failure. They're going to say, I'm short of breath, or I have chest pain, or I've been throwing up. So for each of the most common acute problems, it's nice to have a checklist for family caregivers about what data should be collected, things like heart rate, respiratory rate, temperature, weight gain, presence of edema. And in addition, you're going to want the family member to collect a little bit of historical data. How long has this problem been going on? What makes it better? What makes it worse? You're probably going to want to instruct the family caregiver to begin assessment with an evaluation of how severe the symptom is. And then you're going to want to have a course of action depending on these different steps. Something like call the office, go to the emergency room, modify the medication dose, and you're going to need to tailor the course of action depending on the goal of care. And if this sounds complicated, I have in my book that I mentioned, I have developed this kind of algorithm for different symptoms for the caregiver, and you may want to have a look at that and modify the list in accordance with what you think makes sense. Just want to give you an example of how the strategy might vary depending on the goal of care. Suppose you have a patient with chest pain. And let's say, for starters, that the primary goal of care is life prolongation. If there's a strong suggestion that the symptoms might indicate a cardiac etiology, that is, it's not clearly indigestion, and if the symptom is very severe, then your algorithm might say, don't go around measuring blood pressure, don't call the doctor's office, just go right to the emergency room. If, on the other hand, the primary goal of care is maximizing function, remaining as independent as possible, trying to stay home if possible, then unless the symptom is extremely severe, it might make more sense to have an office visit. And if the primary goal of care is comfort, then you'll probably want to start with home treatment, things like nitroglycerin and oxygen, at least on a trial basis. And the final step in what you need to do in developing a partnership with family caregivers is to teach the caregiver to navigate the healthcare system. Your frail older patients, sooner or later, may need home visits. They may go to the physician's office. They'll probably end up in the hospital, and they're very likely to take advantage of rehab or post-acute care. So at each of those sites, you need to help them figure out what's important, who's important, and how the system works. And again, my book might be helpful in elucidating a little bit more about each of these sites. So to develop an effective partnership, you need a willing patient, you need an available family caregiver, and you need to have your office set up to facilitate communication. There are lots of resources that can help you. If you have available an interdisciplinary team, especially a nurse practitioner or a physician assistant, that can be invaluable. Community resources, for example, the visiting nurse, adult day health, senior center, can be useful. Educational materials, for example, pamphlets, videos, books, all of these can help you. So the final thing that can help, I would hope, again, is to equip your patient and family caregiver with the medical knowledge that they need to be an effective partner with you in this relationship. And once again, my book, I hope, will be helpful. So go forth and develop these partnerships. I think you're going to find it makes taking care of your frail elderly patients easier for you, more effective for them, and increases the chance that they're going to get top quality care that's consistent with their preferences and goals.